Hi everyone, welcome back to the EKG series. I'm Ian, one of the PGY2s at BI. Today I'll be joined by Dr. Shu Yang, an electrophysiologist here at BIDMC, and we'll be talking about identifying atrial fibrillation and atrial flutter on EKG. So we'll start off with some objectives for today. So first we're going to identify key characteristics of atrial fibrillation on EKG. We're going to identify key characteristics of atrial flutter on EKG. We're going to review the electrical conduction mechanics of atrial fibrillation and atrial flutter and correlate with EKG findings. And then we're going to differentiate atrial fibrillation and flutter on EKG. And then as a bonus, we're going to relate the pathophysiology of the conducting system abnormalities seen in these conditions to differences in management of atrial fibrillation and flutter. So let's start again with a warm-up EKG. Take a look at this EKG and remember to try to go through systematically for rate, rhythm, axis, and convince yourself of why for each one of those pieces. Try pausing and testing yourself before moving along in the video. So breaking this down, for rate, it's a bit hard to count between QRS intervals or R to R. So we'll go ahead and count across and we'll get 13 by 6, which equals about 78 beats per minute. For rhythm, we start by looking for atrial activity in leads 1, 2, and AVR, where our normal sinus P waves would be visible. But we see the absence of P waves and irregular distances between the QRS axes without a discernible pattern here. A so-called irregularly irregular rhythm, putting them together. Both of these findings together point us towards Afib as our rhythm. Now, just to round things out, we see our axis is normal with an upgoing QRS in 1, 2, and AVF, making a normal axis. And then for a quick pathology bonus, we see scooping ST depressions here in the inferolateral leads, which can be associated with the digitalis effect from digoxin. So going into some quick definitions and classifications of Afib, atrial fibrillation is a disorganized atrial rhythm that leads to irregular contraction of the atria with the impulses intermittently conducted through to the ventricles. One important means of classifying Afib is categorizing into valvular versus non-valvular. For valvular, which we see less often, this is characterized by moderate to severe MS or a mechanical prosthetic valve being present. It has a high risk of stroke, and these patients should be anticoagulated with warfarin. For non-valvular, these patients can still have valvular disease, just not moderate to severe MR or a mechanical valve, and can be treated with DOACs for anticoagulation. Some important things to consider with this valvular bucket. You may be asking, as I was, why we make this differentiation. Well, it turns out that the patients with these aforementioned valvular conditions may be at a higher risk for stroke, with a hazard ratio estimated to be 1.1 to 1.3, comparing valvular to non-valvular without a mechanical valve present. And these patients just haven't been studied as much with respect to trials looking into DOACs. Another population to consider is those with recent bioprosthetic valve placement in Afib who follow a different set of rules for anticoagulation in the first 3 to 6 months following implantation. The other way you are likely to see Afib categorized is by time course definitions, which are outlined below. So we start with paroxysmal Afib, which is characterized by episodes that terminate spontaneously within 7 days of onset, typically within 48 hours. Then moving along, we have persistent Afib, which is episodes that last more than 7 days or require termination by cardioversion. Third, we have long-standing persistent Afib, which is continuous Afib lasting for more than 1 year. And then finally, we have permanent Afib, which is Afib where a decision has been made not to attempt to restore sinus rhythm, either because cardioversion has failed or has not been attempted, i.e. maybe the patient cannot tolerate anticoagulation due to cirrhosis and history of recurrent GI bleeds, and so rhythm control is not an option with cardioversion for those patients. Now let's try to break down the pathophysiology of Afib here. A simple way to think about this is starting with focal or aberrant ectopic atrial electrical activity, which can commonly be observed in the pulmonary veins. This can lead to propagation of a focal impulse through multiple wavelets across the left atrium, and this may lead to multiple micro-reentrant circuits that perpetuate this disorganized and chaotic atrial fibrillatory waves. Note that larger and more dilated atria permit for more space for these impulses to wander or form micro-reentrant circuits, showing how dilated LAs can be a risk factor for AFib and make it harder to break back into sinus. This will lead to chaotic and irregular contraction or fibrillation of the atria, which can be captured on an EKG as these so-called fibrillatory waves. These disorganized impulses only intermittently sneak through to the ventricles through the AV node, hence leading to our variable RR intervals that we see in AFib. Now, it's important to understand that while these mechanisms of atrial fibrillation origins fit nicely with what we observed, the exact origins of the initial and disorganized atrial ectopy is uncertain. One theory posits that origins in pulmonary veins lead to premature impulses and subsequently this atrial R on T phenomenon, similar to what we see in the ventricles, leading to disorganized fibrillation, while others posit that the original atrial ectopy will lead to formation of multiple micro-reentrant circuits, which leads to wandering wavelets and fibrillation throughout the atria. With this in mind, let's look back out at our primer EKG for some practice and breakdown. So, as we see, our rate is quite elevated at around 170 BPMs, which certainly constitutes an AFib with RVR, characterized by AFib with a rate of greater than 110 beats per minute and can often be much higher. Looking next at our rhythm, when we look for our P waves or organized atrial activity in 1, 2, and AVF, we don't see any discrete organized P waves or organized atrial waves for that matter. Furthermore, if we start looking at our QRS complexes and at the RR interval, we see an irregular, non-repeating, or irregularly irregular RR interval, both of which are very much characteristic of AFib. Then if we look very closely here, we can convince ourselves maybe of the presence of some fibrillatory waves, which line up with the physiology of AFib as discussed, though this could alternatively be artifact or tremor, and in this case is more so just to communicate the point of looking for these fibrillatory waves. These are a lot easier to see in sections where the rate is a little bit slower and there is more space between the QRS complexes. Now let's take a moment to review our key findings of atrial fibrillation. First, we're going to look for those irregularly irregular RR intervals, that is, repeating without a discrete or identifiable pattern. But what about other rhythms which may lead to irregularly irregular RR intervals, like multifocal atrial tachycardia, wandering atrial pacemaker, or Aflutter with variable AV block? Well, for that, we should be looking for the presence of organized atrial activity / P waves, bringing us to our next key finding in atrial fibrillation, which is looking for the presence of these so-called fibrillatory waves, which correlate with our physiology of multiple wandering wavelets across the atria that might lead to or form from multiple micro-reentrant circuits with disorganized electrical activity and this fibrillatory chaotic pattern on EKG. Finally, we should confirm the absence of P waves or organized atrial activity for that matter, which helps further support AFib as our diagnosis while differentiating from other irregularly irregular rhythms as mentioned above, and helps us distinguish from pseudo-AFib, artifact, or tremor, which we'll talk about a little bit later when we practice as well. With all that said, if you're like me, you might be wondering if we have all of these chaotic fibrillatory electrical impulses, why are patients with AFib not always catastrophically tachycardic? Now, this has to do with the AV node serving as the gatekeeper of atrial impulses getting through to the ventricles. The AV nodal refractory period usually dictates the conduction of these erratic impulses from the atria to the ventricle in the absence of an accessory pathway. So we start out, we have our chaotic fibrillatory impulses which arrive at the AV node. The AV node acts as a good floodgate and filters out many of the impulses which arrive while it's refractory, and then the ventricles only see a few impulses, leading to a relatively normal ventricular rate. But then we get factors that increase sympathetic tone. Think sepsis, thyrotoxicosis, or abnormalities which may alter myocardial conduction, make it more hyperexcitable, like electrolyte disturbances, hypomagnesemia, things like that. These can decrease the AV nodal refractory period and lead to more impulses conducted through and potentially reaching the ventricles, possibly precipitating AFib with RVR. This AV node gatekeeper action helps illustrate why beta blockers and calcium channel blockers that act directly on the AV node and elsewhere throughout the myocardium can serve as effective rate control agents for AFib. Let's take a brief pause here. This is a decent amount of info and covers some of the basic key concepts for understanding AFib. If things are unclear or uncertain, please take a moment to pause here and reflect, quiz yourself, or re-watch any portion of the video to refresh before moving on to the next topic. Now we come to another practice example. So what's the rhythm here? Again, pause to make sure you are testing yourself. Remember to break it down with our classic rate, rhythm, axis, intervals, pathology, strategy to build up that systematic habit. So this is actually a nice example of typical counterclockwise atrial flutter. Let's find out why and dig a little bit more into this condition. So atrial flutter is an organized ectopic atrial rhythm resulting from macro reentrant circuits that form in the atria, most classically at the cavo-tricuspid isthmus, or CTI, around the tricuspid annulus. The key when thinking about classifying flutter comes down to two general points: location and the direction of the reentrant circuit. Each classification category is essentially just a categorization based on that. We have typical flutter, which is a macro reentrant circuit at the CTI, mostly resulting from counterclockwise reentry of this circuit in about 90% of the cases, and clockwise reentry in about 10% of the cases. Typical flutter is located at this CTI, and that has very important treatment implications for the condition, as this is a region that is more easily localizable and accessible in the EP lab when going in to ablate this abnormal rhythm and conduction. Then we have atypical flutter, which is a macro reentrant circuit which is located elsewhere in the atria. This is associated with reentrant pathways that form around prior ablations, scars, and structural disease in the atria, which can be a little bit more tricky to try to go in and ablate just based on localizing it and actually accessing the macro reentrant circuit, as it could be over in the left atrium. Now, you might be asking, why is the CTI a common place for flutter? So this actually comes down to one of the basic themes of reentrant circuits in electrophysiology, which is slow conducting pathways repolarize fast and fast conducting pathways repolarize slowly. The CTI is a region of slow conduction that is quick to repolarize. Therefore, when there is presence of an aberrant or ectopic atrial electrical impulse while other regions of the right atrium are refractory, the CTI is repolarized and able to conduct, leading to the formation of a circuit as the impulse propagates out from it to the rest of the atria. Let's go ahead and look at this in greater detail. So, let's break down the physiology of typical flutter as an example, and we can apply this concept to the remainder of flutter as it just translates basically to a different direction or location of the reentrant circuit. So we start with an aberrant atrial impulse, or PAC. This will lead to a brief transitional rhythm which will start the reentrant circuit at the cavo-tricuspid isthmus. Remember that the CTI is slow to depolarize, fast to repolarize, and so it was ready to receive this signal faster than the rest of the atria. As the rest of the annulus near the CTI wakes up and is ready to depolarize, the impulse rotates around the CTI and then propagates through the atria, spreading outwards. It will intermittently get conducted through to the ventricles based on AV nodal conductance. This translates on EKG to flutter waves which are regular and consistent at about 300 BPMs, which is classic for flutter. Intermittent conduction through the AV node is typically observed classically in a 2-to-1 pattern, leading to a ventricular rate around 150. You might be seeing this axis down at the bottom too, which shows the direction of the impulse of the atrial wave relative to our normal EKG axes, which will help us understand how we can differentiate counterclockwise from clockwise typical flutter going forward. As we can see, we have negative flutter waves in our inferior leads, which makes sense based on the direction of the atrial impulse axis as shown here. Now let's apply what we know and break down our example from before. Looking at our rate, it's about 140 by counting across and 150 by the box method, which is a classic finding for a flutter with 2-to-1 electrical conduction impulse. Okay, so that's our ventricular rate. Now let's look at the atrial rate. See how we have atrial waves separated by one box? This is equivalent to about 300 beats per minute in the atria, which is classic for flutter. Onto our rhythm. So we do not see classic sinus P waves here. Then we see our classic flutter waves for counterclockwise typical flutter, where downwards are negative in 2, 3, and AVF, these inferior leads, which again makes sense based on the direction of our axis that we saw in the last slide, and we're positive in V1.
So with typical clockwise flutter, which is our most common type of flutter, we have some key EKG characteristics. So first of all, our atrial rate is around 300 beats per minute. Remember that flutter is a macro reentrant circuit, and thus our atrial rhythm is fairly regular. An atrial rate of 300 is fairly and relatively specific for flutter and is seen for the most part across all types, not just our typical clockwise flutter. Next, we think about our ventricular rate. So in the absence of variable conduction, our atrial rate of 300 is usually divisible by the ventricular rate. This reflects the ratio of these regularly conducted flutter waves generated from our macro reentrant circuit around the CTI sneaking through the AV node, resulting in rates of 150 for 2-to-1 conduction, 100 for 3-to-1, and 75 or so for 4-to-1 conduction. Note that 1-to-1 conduction is unlikely to be sustained. It is exceptionally dangerous, especially if your atrial rate is 300, with the propensity to degenerate into VFib. Then finally, with typical counterclockwise or our most common form of flutter, we'll see these upwards or positive flutter waves in V1 and downwards or negative flutter waves in the inferior leads of 2, 3, and AVF. So now that we've covered our most common form of flutter, let's hear from Dr. Yang on some of the more subtle findings that we might encounter.
Right. So thanks for joining me, Ian. Like I said, my name is Shu. I'm one of the electrophysiologists here at the Beth Israel. I've been here for a while, so very excited to see that we are working to incorporate some more in-depth EKG teaching and learning into our residency curriculum. So this is another example of atrial flutter from a case that I actually mapped and ablated in a patient. As spoilers, I know exactly what kind of flutter this is, but looking at the EKG starting in the same way that we had mentioned before, we know that atrial flutter is an organized atrial arrhythmia with pretty continuous organized atrial activity, either in the right or the left atrium. And in this situation, you can see that there are flutter waves, and the numbers are pointing out 1, 2, 1, 2, 1, 2, 1, 2, meaning that there are 2 flutter waves occurring for every QRS complex. So this is some sort of 2-to-1 atrial flutter. The question is, what kind of flutter is this? And one of the things that we have sort of suggested or alluded and have all experienced at some point is that it's hard to tell sometimes whether flutter is positive or negative in any given lead. And I'll be honest, with this case, I actually made the mistake thinking the polarity was one way and it ended up being the other. So in retrospect, how do we make sure that we have everything correctly? So the first thing you want to do is find a flutter wave, ideally, where there's no interruption from a significant T wave or a QRS complex. And if we draw an imaginary line here from where the flutter wave starts, we can say that, look, this is potentially the onset of a flutter wave. And this is a little subjective, I'll be honest, but if you look at the inferior leads 2, 3, and AVF, typically this is the best place to see it. And you get this initial sharp upslope and then more rounded secondary component. And if you march this line all the way up, you can see that it's probably slightly negative, more negative than positive in V1. And it's more positive than negative in the inferior leads. So this is the opposite of what we call typical counterclockwise flutter. And this is an example of typical clockwise flutter. So we're revolving in a clockwise orientation around the tricuspid valve. And when we say clockwise, I mean if you're looking at the tricuspid valve from the perspective of the ventricle, and 12 o'clock is the anterior part of that valve, 6 o'clock is the inferior part of that valve, 3 o'clock is septal, and 9 o'clock is lateral. It's revolving in a clockwise direction. And so to finish this EKG read, obviously there is a clear right bundle branch block as well. So in summary, this is a clockwise typical flutter with 2-to-1 AV conduction and a right bundle branch block. So here we have an EKG of a different flutter. And again, the best leads look at the P wave in sinus and in flutter oftentimes are the inferior leads. So lead 2 is an example. You can see there's regular atrial activity that's pretty organized throughout. And in V1, again, there's regular atrial activity that's consistent throughout. But what you'll notice in contrast to the prior EKGs where there's a very fixed relationship between the flutter waves and the QRS complexes, and there was a very regular relationship between the QRS complex, so what we call a stable RR interval. In this case, there's a varying relationship. Here, it looks like you have 2 flutter waves for every QRS. Here, it looks like it spaces out to about 3 flutter waves for QRS, and if you look towards the end, that's actually 4 flutter waves for QRS. So this is an example of what we call variable. 2-to-1, 3-to-1, 4-to-1, variable A atrial to V ventricular conduction. And now the next question we have to ask ourselves is, well, what kind of flutter is this, right? This is an EKG course. And if we start again by trying to find an area where there's no interruption from the QRS complexes or a big T wave on the flutter wave, so you'll see this purple line drawn down here, you can get a sense that in lead 2, this is where the flutter wave starts and it's positive. Well, I want to know what V1 is, right? I want to know what's happening in the anterior precordial leads. Well, you know where the flutter wave starts, you can pull a line back over, and now you can see that it's both positive, predominantly in lead 2, and an inferior lead, and it's predominantly positive in V1. So this would be an example where you cannot say, based on the EKG, that this is a typical flutter. What I mean by typical, as we'll get to in a little bit, and we've alluded to before, is that this is not definitely an arrhythmia that is circling around the tricuspid valve that utilizes that cable tricuspid isthmus, that tissue that we can easily ablate and reach from the right side. So when I see this flutter as an EP going to do a procedure, I think, all right, I have to be willing and ready to go transeptal to ablate something that may be in the left atrium, that may be in the septum, that between the atria. So that's how I view this EKG. And of course, there's a narrow QRS complexes throughout, and we did do a full read, but there's really not too much to remark apart from some low voltages across the precordial leads in the QRS complexes. So in summary, this would be what I would call an atypical flutter, or you might hear me say or hear me say in a note, this is not necessarily compatible with typical CTI, cavo tricuspid isthmus dependent atrial flutter. So we spent some time talking about typical atrial flutter, atypical atrial flutter. Now, clinically, why does it matter? I sort of talked about it in the last slide, in that it really helps us frame how we're going to approach the procedure. And the way that we electrophysiologists think about the EKG is that it gives you a zip code of where you're looking for, right? If I see something that's very compatible with typical atrial flutter, I think it puts me in the zip code of the right atrium and the the tricuspid valve. But if I see something that's not clearly typical, I expand that potential zip code, and it's harder for me to get a specific address because it could be in the left atrium, it could be far in the lateral wall of the atria, it could be in the septum or the right atrium. So to give you a specific example, if I see typical atrial flutter on an EKG, I'm already anticipating that this is going to be a direct path that I can take from the right femoral vein, which is where we typically get our access, up through the iliac network into the IVC directly into the right atrium to access this circuit that's revolving around the tricuspid valve. And shown here is a view of the heart sort of from the right side in profile, with the right ventricle on the right atrium here on the left, and then the IVC and SVC shown there. The tricuspid valve with that blue circuit shows a CTI dependent flutter, and that CTI again is that cable tricuspid isthmus coming from the IVC, so C for cable, to the tricuspid valve, and the red dots show where you would do your ablation. And to give you another frame of reference, this is that clock face that we were talking about. Looking at the tricuspid valve from the ventricular side up into the atrium, 12 o'clock is up top, 6 o'clock is at the bottom, 3 is septal, and 9 is lateral. And shown here in red is an example of counterclockwise, right? Going in the opposite direction of where the clock typically turns, atrial flutter. And again, if I see an EKG that's compatible with counterclockwise typical flutter or clockwise typical flutter, I know that I'm going to be able to access it directly, and it's going to be a more straightforward ablation. Whereas if I see an atypical flutter on EKG, I better be prepared to take care of anything. And shown here is, again, an en face view looking from the ventricles into both the atrium. On the left side is the right atrium, on the right side is the left atrium. And what you can see is that the red arrows show revolving circuits around the right pulmonary veins here. And on the right side, the left pulmonary veins, there can be circuits that revolve around the mitral valve. There can be circuits revolving around the roof of the left atrium. And there can be other circuits in the right atrium as well, particularly in patients who have undergone cardiac surgery that have scar in the lateral right atrium from their right atrial cannulation sites. And lo and behold, it's hard to tell until you get into somebody's heart and really define with a mapping catheter where the circuits are. But if I see a typical flutter on an EKG, all that tells me is that it's going to potentially be a more complex ablation.
Now, putting together some key side-by-side points comparing atrial fibrillation and flutter, we have the following. Afib is a disorganized and chaotic rhythm, while flutter is an organized macro-reentrant circuit, classically in the right atrium around the CTI. Afib is characterized on EKG by erratic fibrillatory waves, while flutter has irregular, about 300 beat per minute flutter waves that are organized and easier to identify as discrete atrial waves. Afib has an irregularly irregular pattern of conductance to the ventricles, while flutter has ventricular conduction by which the atrial rate of 300 is usually divisible, in the absence of a variable block.
In terms of treatment of atrial fibrillation, atrial flutter, one takeaway here, and just to simplify something that's pretty nuanced, specifically with respect to rhythm control of Afib versus atrial flutter, is that atrial flutter is a very macro reentrant circuit, like we've alluded to. So if you can, with a catheter or with something else, ablate and cauterize or scar away a critical limb of that circuit, you can cure it. So ablation can cure atrial flutters. Not all the time, but with a relatively decent success rate, over 90% with the CTI typical atrial flutters. They're, in contrast, more difficult to manage with medicines that tend to slow down these circuits. And if you imagine, you give a circuit, you have a circuit and you slow it down, you can actually make it a little bit more incessant of a problem. In contrast to that, atrial fibrillation is a very disorganized rhythm. It's harder to cardiovert than an atrial flutter. It requires a little bit more energy. It's more difficult to ablate in the sense that you cannot cure atrial fibrillation. We definitely offer ablation for atrial fibrillation as a management strategy. And in contrast to atrial flutter, where we target a specific circuit that's dedicated to a specific arrhythmia, we take a more anatomic approach where we ablate the pulmonary veins or the posterior wall of the left atrium, areas where ectopy typically originates and triggers atrial fibrillation. And medical therapy does tend to work a little bit better with respect to rhythm control for atrial fibrillation. So hopefully that provides a little clarification.
Now that we've covered our key concepts, let's go through a few more practice EKGs. Really try to pause and analyze these EKGs, as we'll be focusing mainly on the key findings and breaking them down. So this EKG is Afib with RVR. We can see the rate is fast at around 156 beats per minute. There are no P waves, irregular RR intervals as shown here. So this EKG is an example of atrial flutter with variable block. We have a rate around 78 beats per minute. For our rhythm, we see no P waves and an irregular RR interval. But is this fib? We see flutter waves that are negative in 2-3 and AVF and positive in V1, making this typical counterclockwise flutter. But then we see a variable number of flutter waves between each RR interval. Seeing 1, 2, 3 there, and then 4 down here. So this is flutter with variable block, meaning there is inconsistency between ventricular conduction of the atrial flutter waves without a specific pattern. This is another means by which we can observe an irregular rhythm on EKG. But how does this happen? So briefly, we have our reentrant circuit, which propagates an atrial impulse that gets to the AV node. Then this is propagated down to the ventricles, leading to our QRS complex. While the AV node is refractory, another impulse cannot be communicated or conducted to the ventricles, leading to presence of atrial flutter waves without a ventricular impulse. Finally, the node is able to conduct again and transmit another impulse to the ventricles, leading to our QRS complex. In patients with conduction disease, the AV refractory period can be variable, leading to variation in conduction from QRS to QRS or ventricular beat to beat.
We're going to put you in a very familiar practice situation for this EKG here. Let's say you're on night float and you get a message from one of the nurses saying, hey, this patient is alarming on telly for new atrial fibrillation, atrial flutter. You look at their history and they've never had it before. Like the excellent intern/resident that you are, you go see the patient at bedside, they're doing totally fine, and you decide to get a 12-lead EKG. And this is what you see. Go ahead and pause yourself here. Go ahead and think about this, and then we'll go through the answer and break this down together.
All right. So as the arrows, the red arrow sign is pointing out here, Ian, this is at first glance something that looks potentially like atrial fibrillation, because you have this undulating fibrillatory pattern, especially in 2, 3 AVF. You can notice mostly in the limb leads. And it's sort of coarse. There's no regular pattern to it. So you might want to call it atrial fibrillation. But if you take a look at the RR intervals, that's very regular. So there should be some suspicion here that something funny is going on. Now, you have ruled out that this is still atrial fibrillation, but maybe somebody has heart block and they just have an underlying escape rhythm that's totally regular. But if you stare at the red arrows And the little P waves, let's call them, that are regularly occurring, it makes you think, geez, could this be artifact? And could there actually be some sort of sinus rhythm, sinus bradycardia going on? And with this particular EKG alone, there are some suspicions that you can have, but I would say you can't rule out anything, right? But what do? A very, very easy way of going about this is to just repeat the EKG. So this is the same patient I saw in clinic with EKG that was repeated. And like I told you, his limb leads are typically what's tremoring, and he had Parkinson's. So we take a moment, you keep the EKG leads on, and when there's very minimal tremor, at some point during that visit, you hit record and obtain, and this is the EKG that you have. It's a little bit faster now. Maybe I got him a little anxious in clinic, but you can very clearly see there are P waves now, and then the R intervals, again, are very regular, and there's no more of that tremor artifact.
So our key learning points and takeaways from this lesson here are as follows. So atrial fibrillation is a disorganized atrial rhythm that results in disorganized atrial conduction and can be identified on EKG by absent P waves and an irregularly irregular RR interval. Atrial flutter is an organized ectopic atrial rhythm resulting from reentrant circuits usually around the CTI, recognized by flutter waves at around 300 beats per minute. An irregularly irregular rhythm is one where there is a variable RR interval that changes beat to beat without a discernible pattern. Examples of this include atrial fibrillation and atrial flutter with variable AV block. And then lastly, physiology ties directly into treatment in a lot of cases. Atrial flutter may be harder to rate control due to the macro reentrant nature of its circuit, but easier to cure if accessible to ablation. I hope you all enjoyed, and thank you for listening.